Thank you very much, and thank you for the organizers to invite me today to talk about this very exciting topic about the immune mechanism in GI cancer. So I would like just to acknowledge that I'm not a GI cancer expert. I'm working in phase 1 clinical trials, and but I'm interested by immunotherapy for more than a decade now. And so for maybe when we talk about the immune microenvironment of cancers, and when you want to maybe draft the interactions between immune cells between them, most of the time you end up with drawings that look like that. And when you show that to a medical oncologist, most of the time they see that and their brain just shuts off and they don't listen to you anymore. So my aim today is really to give you some practical points about maybe the immune microenvironment of cancers and what we understand about this new field of immuno-oncology across tumors and especially in GI cancers. So even if there was a very strong skepticism about immunotherapy in oncology for the last 20 years in the medical oncology field, it was quite accepted that the immune system had maybe a role in the immunosurveillance, so at the very beginning of the cancer history. And that was supported by preclinical data in mice where when you treat mice with carcinogenic chemical products and you do that in immunocompromised mice, you see that the incidence of cancers and the delay of onset of cancers is much higher than in these immunocompromised mice than in immunocompetent mice. And so that was supporting maybe a role of the immune system, at least at the beginning, to prevent the emergence of tumors. Also in humans, the history of AIDS and HIV infections showed us that immunocompromised patients had a much higher rate of cancers. And when the antiretroviral therapies arrived, the incidence of cancer in these patients basically came back to the level of immunocompetent patients. So again, emphasizing on the role of the immune system to prevent the appearance and the development of cancers in humans. But what we've learned around the early 2000s was a bit different. We started to understand that the immune system was not just a good guy in the story, and we have subsets of immune cells that also play a role to promote cancer. And we now have good tools to identify specifically these subsets of immune cells that are prone to promote the tolerance of cancer cells. We know that subsets of CD4 cells, such as regulatory T cells, or subsets of myeloid cells, such as subsets of macrophages and dendritic cells, together with the cancer cells, create this immunosuppressive microenvironment which will inhibit the anti-tumor immunity of patients. Looking at pathways involved in this phenomenon, one of the first pathways to be identified were the CTLA-4 and PD-1 pathways. So both molecules work as co-inhibitory receptors for T cells. And so when a T cell recognizes a tumor antigen presented by an MHC molecule, if we have these B7 and PDL1 expression, it will end up by the inhibition and not the activation of these T cells because of the expression of CTLA-4 and PD-1. And so the very new paradigm that emerged with this rationale was to design drugs, and especially antibodies, to target these pathways, these immunosuppressive pathways, and so targeting immune cells rather than cancer cells. So in terms of paradigm shift, it's pretty big because so far we've been focusing on the cancer cells to treat cancer patients. And this new paradigm basically says we don't care about the cancer cell, all these abnormal mutations that maybe they bear. Maybe we should more focus on the immune cells and the tolerance of these abnormal cells by the immune system. And designing drugs to target the immune system in order to help him to be activated basically say that you will help your patients to treat their own cancer with their own immune system. So it's a very new paradigm in terms of treatment of cancer. So as you know, the two first generation of drugs were the anti-CTLA-4 and anti-PD-1 antibodies. So the anti-CTLA-4 showed a very significant activity in melanoma, because it showed basically that you can cure metastatic melanoma patients, but although it was in a small proportion of patients, maybe just 20%. But it also showed some activity in other cancer types, and notably hepatocarcinoma, and that was a work performed here in Spain by Bruno Sangro and Nacho Melero in Pamplona. With the anti-PD-1 story, we discovered that the spectrum of activity was much wider than the anti-CTLA-4, and it's pretty impressive to see that over the last 3 years we have described this sensitivity to a single blockade of PD-1 or PD-L1, the ligand, and we have now more than 20 different cancer types that can respond to this single blockade, this single immunosuppressive pathway blockade. So I think in terms of message it's pretty strong that it makes sense to target tolerance in the microenvironment of tumors in order to treat cancers. But it also raises questions of mechanism of action for these drugs. So one of the first biomarker that was suggested to explain the activity of these anti-PD-1 or anti-PD-1 was that the level of expression of the ligand PD-L1 in the tumor microenvironment was maybe a sign that there was an ongoing immune response, and that blocking this immunosuppressive pathway would make sense. And so we have a lot of data now in lung cancer to support that the higher the level of PD-L1 expression, the better you have a chance to have patient responding to an anti-PD-1 or anti-PD-L1. What we know about PD-L1 expression is basically in cancers expressed in two ways. You have either a constitutive expression of PD-L1, where all cancer cells will become positive for PD-L1, and this is usually the case under an oncogenic stress, such as EGFR mutation, ALK translocation, 9p24 amplification, for instance. But this is maybe just a small proportion of cancers, maybe less than 10% of cancer patients. The vast majority of patients have an inductible expression of PD-L1 in the tumor microenvironment. And this is a physiological pathway where you have, when a lymphocyte will attack a cancer cell or any LC cells, it will release interferon gamma. Interferon gamma will then end up by an upregulation of PD-L1 on the membrane of the attacked cell, and the PD-L1 expression will then dampen the signal and inhibit the activation of the T cell. So this inductible pathway, which is the common phenomenon, explains why you might have some heterogeneity in the PD-L1 expression in tumors, because it will be mostly where you have immune infiltrates that you can see this PD-L1 expression. And it raises questions about our ability to conclude about a status of PD-L1 when we come up with just a single tumor biopsy, and we can miss maybe these areas where PD-L1 is expressed. Of course, because PD-L1 can be expressed upon interferon gamma exposure in any healthy cells, because it's a physiological pathway to prevent autoimmunity, PD-L1 can be expressed in many cell types and not just the cancer cells. And we know that fibroblasts, macrophages, even activated T cells can be PD-L1 positive, and activated T cells can also be PD-1 and PD-L1 double positive. So it's not clear right now what is, between all these different interactions between PD-1 and PD-L1, what is the critical pathway that we need to block with our anti-PD-1, anti-PD-L1 in order to generate the clinical activity of these drugs in patients. It's also unclear what is the definition of a PD-L1 positive patient, because every company has developed its own IHC immunohistochemistry assay to define the expression of PD-L1. So every company has its own clone of antibody, its own assay, and they have different ways of looking at PD-L1 expression, either on the cancer cell alone or cancer cells and the immune infiltrative cells in the stroma. And they have different thresholds between companies for the same tumor type and across diseases. So again, it's complicated to have a clear vision of what is a PD-L1 positive patient. What is interesting in the GI space is that we have now multiple different cancer types that have been described to be sensitive to a single anti-PD-1 therapy. We know that esophagus, gastric, anal, hepatocarcinoma, and biliary tract cancers can respond to an anti-PD-1 in second-line treatments or third line. So the level of response is probably low, between 10 and 20% for the different tumor types. But on top of that, you have a significant proportion of patients that also have stable disease. And this stable disease also contribute to this overall clinical benefit of patient, and probably explains partly why we have so many phase 3 clinical results that are now positive for anti-PD-1 monotherapy and with benefits in overall survival for patients as opposed to classical and conventional second-line treatments. What was more surprising was the low level of activity of anti-PD-1s in colorectal cancer. Because as you know, colorectal cancer has been known for years now to be a cancer which depends partly on the immune system in terms of prognosis, and this is the work of Jérôme Gallon and his immunoscore, basically saying that the higher the level of CD8 cytotoxic T cells in the tumor, the better the survival of colorectal cancers. So we could expect that maybe in these cancers we will have some activity of anti-PD-1s, but so far most colorectal cancers have very little activity, if known, at least for the MSS subtypes. What has been pretty surprising was the level of activity in MSI positive colorectal cancers, where there we have a very high level of response rate, maybe more than 60%. And the way we explain this sensitivity to anti-PD-1 in these cancers is that the accumulation of somatic point mutations with these mismatch repair deficient cancer cells will end up by the production of abnormal proteins, and these proteins will generate peptides that will be neoantigens and recognized by the immune system as abnormal molecules. And so a T cell can recognize these neoantigens as abnormal. They can start to react against the cancer cell. And as we said before, when they become activated, they will release interferon gamma, and interferon gamma will end up by the upregulation of PD-L1 on the membrane of cancer cells, and this will eventually inhibit the anti-tumor activity. So in these MSI patients, it's probably why when you come up with an anti-PD-1 antibody and you block this immunosuppressive pathway, you unleash these T cells and the activation of these T cells, and you allow to have a full activation of the anti-tumor immunity. We have also confirmation of this neoepitope and neoantigen story in other cancer types. We know that these neoepitopes can contribute to the clinical benefit of anti-PD-1s in melanoma, but also in non-small cell lung cancer. So it partly explains probably the sensitivity of anti-PD-1 in highly mutated cancers where they have the high proportion and high probability of generating neoepitopes and neoantigens. However, there was a very interesting result in colorectal cancer that's showing that maybe the level of immune infiltration in tumors and the MSI status is not maybe strictly redundant. And this is also some work performed by the Jérôme Gallon team showing that you can have MSS colorectal cancers with a high level of CD8 T cell infiltration that have a much better outcome than MSI tumors, as shown in green here, but have with a very low level of immune cell infiltration. So maybe this level of somatic point mutation does not explain everything for the sensitivity to an anti-PD-1 monotherapy. And it is also supported by the data across tumor types, where we don't find a strict correlation between the level of somatic point mutation in the cancer genome and the sensitivity in terms of objective response rate with an anti-PD-1 monotherapy. Indeed, we have other pathways that can be involved to explain the immunogenicity of a cancer cell. As we said, we have these accumulation of mutations that can end up by the production of tumor-specific antigens and neoepitopes. But we also have epigenetic modifications that can generate the re-expression of tumor-associated antigens, such as carcinoembryonic antigens like CEA on the tumor membrane. And we know that these tumor-associated antigens can be recognized by the immune system and contribute to the overall immunogenicity of tumors. We also know that some constitutively activated pathways in the cancer cells, such as oncogenic stress, can end up, as we said, to the upregulation of PD-L1 on their membrane, but also on the secretion of subsets of cytokines such as IL-10, TGF-beta, that will contribute to the immunosuppressive phenotype of the cancer cell. And also, these mutation and epigenetic modification also can have an impact on the level of expression of MHC molecules and also contribute to the overall immunogenicity of these cancer cells. More recently, we've learned that the microbiota is maybe important also to explain the activity of these immune checkpoint targeted antibodies. And of course, for GI cancers, it makes a lot of sense to be interested by this question. So we just have, for now, preclinical results in mice, but the results are pretty striking. You have here an illustration of the impact of the microbiota on the activity of anti-CTLA-4. You can see on your left that anti-CTLA-4 in this specific tumor model has some anti-tumor activity, as shown in black. And when you treat the same mice with the same tumors, but without any microbiome, without any bacteria in their gut, you completely lose the activity of anti-CTLA-4 therapy. So that was a work performed by Laurence Vogel at Gustave Roussy, but there is another work published in the same issue of Science by the team of Tom Gajewski, also showing the impact of this microbiome on the activity of anti-PD-L1 antibodies. And you have here an illustration of the fact that all pathogens, all bacteria are not equivalent to help to generate the activity of these immune checkpoint antibodies. And here for Bifidobacterium, for instance, they seem critical in this tumor model to enhance the activity of anti-PD-L1s. So then comes the question of what is the future of oncology with these new drugs. The first thing that we want to do is, it's a bit incremental, but still it's valid, is just to combine our past conventional therapies, cytotoxic therapies, with immunotherapies. And we have results in some types of cancer, such as lung cancer here or triple-negative breast cancer, where it seems that chemotherapy in combination with an anti-PD-1 or anti-PD-L1 might be synergistic. But that might be a bit counterintuitive to combine a product which is known to be toxic for the immune system in combination with an immunotherapy. So there are some data and there is some rationale to support this idea. Again, in mice, there is some work that has been published over the last 15 years showing that some chemotherapies actually rely on the immune system to have their whole activity. And you have here an illustration in mice where when you treat mice with a chemotherapy such as mitoxantrone, which is an anthracycline, you completely lose the activity of the chemotherapy, as shown in blue on the right panel, when you work in immunocompromised mice. Also, it has been shown for radiotherapy that if you work in mice that are knocked out for the receptor for type 1 interferon, which is a critical cytokine for the immune system, you completely lose the efficacy of radiotherapy. Same for some tyrosine kinase inhibitors. It has been shown that for this illustration here, when you deplete CD8 T cells, you completely lose the anti-tumor activity of dasatinib in this tumor model. So again, emphasizing that these historical cytotoxic therapies might partly rely on the immune system to be active. And we have now a pretty strong set of data supporting this rationale and how these cancer cells can generate some immunogenic cell deaths. We know that cancer cells that are dying can release ATP in the tumor microenvironment, and this ATP can act as a chemotaxis signal to recruit dendritic cells, so antigen-presenting cells, within the tumor microenvironment. We also know that HMGB1, a protein which is usually expressed in the nucleus of cells, once it's in the tumor microenvironment, can act on these antigen-presenting cells by acting on the toll-like receptor 4 pattern recognition receptors, and then modify the phenotype of these antigen-presenting cells and activate them. We also know that calreticulin is a protein expressed usually in the reticulum within cells. Once it becomes outside of the cell, it will act as an eat me signal and help to perform phagocytosis by these antigen-presenting cells, and again, supporting the presentation of cancer cell antigens to the immune system. So all these pathways contribute to have some immunogenic cell deaths of cancer cells for some therapies. The other strategy for the near future would be to stop working with these past conventional therapies and try to use other immunotherapies together. So we have now these two first antibodies, anti-CTLA-4 and anti-PD-1, that are largely developed in cancer types such as melanoma. It's already approved in the US for this indication in combination. But we also saw some very interesting results in lung cancer at ASCO for the combination of anti-CTLA-4 and anti-PD-1. But it's not just about immune checkpoint antibodies and T-cell targeting antibodies. We also have plenty of new drugs in immunotherapy that are of great interest and probably of interest for GI cancer. One that I wanted to mention is the family of IDO inhibitors. These are oral inhibitors, so not IV, such as the immune checkpoint antibodies. And they have shown very interesting results in melanoma in combination to an anti-PD-1 and seem maybe synergistic in this indication. And so IDO is an enzyme which is expressed in the tumor microenvironment, and this enzyme depletes tryptophan, and tryptophan is a critical amino acid for the biology of immune cells. And so when you don't have any tryptophan in the microenvironment, then your immune cells will not perform efficiently. So when you come with an IDO inhibitor, then you allow the immune system to be more performant, and you can unleash the immune system better in combination with the anti-PD-1. And you had also some interesting results of IDO inhibition at ASCO presented in combination with chemotherapy in pancreatic cancer. So IDO inhibition is probably a good pathway to be targeted in GI cancer. Another strategy of interest right now is the strategy using oncolytic viruses. So oncolytic viruses is not new in the oncology space, but the novelty is that the first one has been approved for the treatment of melanoma. It's a TVEC. It's a virus such as herpes virus modified to preferentially infect cancer cells and trigger the immune system. And we have, again, some interesting results in melanoma in combination with anti-PD-1. And so maybe this type of combination would be great to prime the immune system against the tumor. And the idea here is really to inject these viruses directly into the tumor to prime the anti-tumor immunity. And so and hope that once you prime the immune system correctly on several lesions, you will also have some abscopal effect and some activity on non-injected, non-treated sites, because once the lymphocytes are correctly primed, they can traffic in the body and act on distant sites. So these strategies may be of interest, especially in tumor types where you have very low level of activity of immune cells or pre-existing immunity against the tumor of patients. Another family of drugs of great interest are the bispecific T-cell engaging antibodies. And again, it's becoming a reality now in the clinic because the first generation has been approved. The blinatumomab anti-CD19, anti-CD3 antibodies approved now for treating refractory or relapsing B-cell leukemias. And the level of activity is here again very interesting because it can put in remission patients that are relapsing for their leukemia. What is behind these kind of drugs is that you have these antibodies with two arms, and you have one arm which will recognize an antigen expressed by the tumor cell, and you can have one arm also recognizing CD3 expressed by T cells, and these CD3 arms are agonistic, so they can activate any T cell in the tumor surroundings. And so the idea here is to force the immune system to be activated against the cancer cell, whatever the level of expression of MHC class 1, whatever the pre-existing T cell specific immune response, you can force the immune system to react. And so you have several bispecific T cell engaging antibodies that are in development right now in the clinic against CEA, and this is maybe of interest also for gastric and gastrointestinal cancers. So I would like to conclude with this slide, which basically shows you all the ongoing combination of immunotherapy in the GI space. Usually people, when they look at such slide, they say, "Wow, it's nonsense. It's combination with everything, and it's completely empirical." It's not fair to say that, and it's not actually correct, because when you look at the scientific publication of the last 15 years, most of the combination have been built on a strong scientific rationale, and you have a broad spectrum of synergistic combination that can work with these immune checkpoint antibodies. So objectively, you can see that clinic will rule in the near future and not science, because we'll have some synergistic combination and some combination that will not be synergistic, and probably some of them will not translate well from mice to humans. But that means that we will have, as a community of oncologists, a very hard task in the very near future to better understand what's ongoing in these gastrointestinal cancers, what is the immune contexture of these subsets of cancers, to explain why in some subset the immunotherapy is working and why in some others it's not working, and why some combination are synergistic and why others are not synergistic. So I think this is our task to build smart ancillary studies within the next clinical trial that we will design to better understand this immune microenvironment and generate some interesting scientific result to find new biomarkers of activity for these treatments. Thank you very much.